Okay, you're good to go.
Good morning. It's April 23rd, 2021. It's so good to see so many bright and shining faces this morning, helping try to make the world a safer and better place. I'd like to begin by reading a statement so that everyone understands why we're meeting on Zoom today. Pursuant to Executive Order 2020-07, 2019 ILEO 20-07, issued March the 16th, 2020, during the duration of the COVID-19 gubernatorial disaster proclamation, the provisions of the Open Meetings Act 5 ILCS 120, requiring or relating to in-person attendance by members of a public body, are suspended. Specifically, the conditions in 5 ILCS 120/7E of the Open Meetings Act, limiting when remote participation is permitted, are suspended. A physical quorum of the HOPE Task Force members is not present for today's meeting. This morning's meeting of the HOPE Task Force is being conducted remotely and is being live streamed for the public's viewing on the agency's YouTube channel, which can be accessed at the live stream link on the Health Department's website. Members of the public had the opportunity to submit written comments in advance of the meeting. The method for public participation is publicized on the Health Department's website. Public comments will be read and recorded in compliance with the Open Meetings Act. I am calling the meeting of the HOPE Task Force at this time, and that is 9:02 a.m., along with my co-chairman, Mr. Greg Hart. First of all, we'll welcome new members and take a roll call. So Andrew Anselm, Director of DuPage Metropolitan Enforcement Group.
I'm here. Good morning, everybody.
Glad you're with us this morning. Thank you. Karen Ayala, Executive Director of the Health Department.
Good morning, everybody. Good to see you guys.
Bob Berlin, State's Attorney.
Good morning, everybody.
So good to have you with us, Bob. Laura Crawford, Executive Director, Chambers 630. Is Laura Crawford with us this morning? Okay. Brad Gerke, I saw you.
Yeah, good morning, everybody.
Director of Operations for Banyan Treatment Centers. Greg Hart.
Good morning.
He's my co-chairman and on the DuPage County Board. Bernadine Howard, Program Manager, DuPage County Drug Court.
Morning.
Dr. Rich Jorgensen, Coroner. Dr.
Good morning. How you doing?
There he is. Hey, good.
Sorry.
Glad you're with us, Rich. Keith Creston, Fire Chief Lyle. Did I see Keith Creston out there? No answer yet. Deb Lewin, Executive Director, Path to Recovery Foundation. Deb Lewin. Sheriff Jim Mendrick.
Sir, I'm present for Sheriff Mendrick, Mike Drugan.
Mike, welcome. A new member, Chief Judge Kenneth Popejoy.
Morning, everyone. I look forward to an active participation with all of you, and thank you for giving me the opportunity.
Really appreciate you being with us this morning, Judge. Dr. Darlene Rossetti, I saw her.
Good morning.
Superintendent. Jim Scarpace, Executive Director, Gateway Foundation. We had heard that Jim may not be able to be with us this morning. I don't see him on the screen. Lisa Schvach, Executive Director, DuPage County Workforce Development.
Morning, everybody.
Would you say your last name for me, Lisa?
Sure, Shavak.
Shavak. I hit it.
You were very close. Thank you.
You're welcome. Another new member, County Board, Greg Schwartz.
Hi, thank you. It's Schwarzy, but I'm so happy to be here. So thank you very much. Thank you.
I guess if it was Schwartz, it would be SCHWARTZ, but Schwartzy has the Z and the E. So yes. Thanks for that correction.
Thank you, sir.
Glad you're with us. Rich Veenstra, Mayor of Addison.
Good morning.
Thank you. Greg Vesta, Police Chief Wooddale.
Good morning, everybody.
Welcome, Greg. And Jeff York, Public Defender.
Morning.
That concludes the membership update, and it's to you, Mr. Hart.
Thank you very much, Dr. Wilson. Want to also welcome my colleagues Dawn Desart and Paula Deacon Garcia, two county board members who are on the line as well. So thank you both for joining in. Commissioner Schwarzy, welcome to the task force. Really appreciate your service. And Member Eckhoff, appreciate all of your service as well. So thank you for being on the line here today. We're going to move to the second item on our agenda, which is the acceptance of the minutes of the January 21st, 2021 quarterly Hope Task Force meeting. Are there any additions, comments, corrections, or deletions? Or do we have consensus from the group that will accept and place on file the minutes? Seeing none, we'll consider those accepted. We appreciate everyone's consensus around that. Penny, is there any public comment?
No, there's no public comment. And just as a note, I'll also monitor muting for you as well. So if anyone is unmuted and has background noise, I'm going to mute you. So sorry. Thanks.
Thank you. And I do just want to remind everyone that in addition to the 30 people we have on the line here today, this is being streamed live on YouTube. So welcome to anyone who is watching from home. So with no public comment, we'll proceed to the other items on the agenda. I am going to, with leave of the body, make a slight adjustment to the agenda. We do have the pleasure of having our DuPage County federal lobbyist, Bill Viney, on the line. I know that he has some time constraints, so I want to be respectful to his availability. So unless there's any concern from anyone on the task force, I'm going to move the state and federal legislative update to the first item on the agenda. And Mr. Viney, I think you're on, aren't you? I think I see him in here.
Yeah, he's there. I see him.
Yeah.
Oops. Looks like he froze.
Bill, you there?
Can you hear me?
I can now. Welcome. How are you?
Good. Sorry, I had my laptop plugged into my monitor and sometimes it doesn't, the speakers don't work. So I apologize.
No worries. Well, and just to set the context for the group, obviously, there's been a lot of action out of Washington specific to the COVID pandemic. And we asked Bill to come on the line today to talk about any pending, past, or new federal legislation that may impact the substance abuse crisis or mental health crises that are plaguing the country. So, Bill, really appreciate you making time out of your busy schedule, and I'll turn it over to you.
Yeah, no, happy to be here today. You know, I don't want to go too long. I'm happy to answer any questions that folks have. But you guys will probably see, and, you know, there's a myriad of bills that were introduced in previous Congresses and this Congress, all related to, you know, substance abuse and misuse. And so, but you know, last week on the 14th, the House held what will be the first of likely a few more hearings on the topic. You know, and what you heard was really the start of the discussion and a change of how in this new Congress, in this new administration, they might look at these topics going forward. You know, as we've seen for the past, you know, couple of years, there was a real emphasis on interdiction and trying to get to the issues through a legal framework, as well as you know, some additional resources provided for treatment and sort of after the effect. What you heard in the hearing last week and what you're likely to hear in a Senate hearing, which is, I believe, set for next week on the same topic, is more focus and almost exclusive emphasis on what happens after the fact, what happens with treatment. And, you know, the previous administrations, you know, have recognized, you know, going back to Obama, that really there's not enough resources to go towards the treatment and sort of the immediate, something that DuPage has been a leader on with the use of items such as Narcan. I think we're going to see this Congress really focused in on treatment and provide more resources, whether it comes through another piece of legislation like the American Jobs Act, which is, the infrastructure package, or the next, what we would think of the next round of stimulus that's being provided, or it happens through some other mechanism. But you see a variety of bills out there, and we can talk about each one of them individually. And today I can't tell you which one's going to pass and which one's not, seems to be the leading contender. At some point, they'll decide which horse they're going to ride and what piece of legislation they're going to attach it to. But I do expect, likely to see authorization and appropriation of additional resources that will, or grants that will be administered through one of the various, health agencies, that will go to states and localities. So likely, if I'm going to get to the end of the game where I think this happening, I think you guys will end up with more resources, whether it is distributed through some sort of a formula or grants. But clearly, it seems like, things are trending that they'll, make a higher priority for, where the trafficking is happening, or where the, rates are highest, probably, some sort of, incentives for income and other criteria. But I would expect in the next, by the end of this year, some legislation enacted through a vehicle that will provide more grants and resources to states, that will, come out in some mechanism, either formula or competitive. The timeline of when I see that happening, probably towards the end of the year. It seems, based on, kind of the dynamics that we're seeing in Washington these days, that things are in the pace that we're moving, that things like we've seen in past years are headed towards an end of the year type item. And what that item will entail, we don't know yet, but I would expect by the end of the year, we'll see something. Prior to that, we may see some bills pass through committee or pass through the House or the Senate individually, but unclear if they'll pass on their own, because we're still relatively early in the process, or if they're going to get bundled into something else. But the good news is, I think you'll probably end up with more resources at the end of the day. Commissioner Hart, I can maybe stop there, and happy to take any questions. Although I'm going to warn you, I'm not a healthcare expert. So if I can't answer your question today, I'm happy to get back to you with a response. And I know I've worked with many of you on the phone. I'm not shy about admitting to what I don't know and coming back with a better answer than me trying to give you something on the fly. So
that's a good thing, Bill. That's what we appreciate. So no, thank you very much for that update. I do want to remind the group, if you do have questions, of which I see there is someone that already does have one, please leverage the hand raise function in Zoom. If that doesn't work for you, please shout out or wave. I'll do my best to manage and monitor the cameras here. But the first question comes from Karen Ayala. Karen, the floor is yours.
Thanks so much, and very good to see you, Bill Viney. He was Chris and my gracious host when we had the awesome opportunity to actually talk about the heroin epidemic at a congressional committee. And he's even better in person. So thanks so much, Bill. My question is, and we've been talking about this increasingly with the ARPA funds and with the nature of this public health pandemic, I really see the issue of mental health and substance use disorder treatment as being an integral part of our community's recovery. Was that considered as in the language of those funds being distributed? Is that going to be something that we as a county and individual communities can consider?
So there were four pretty broad criteria that were actually put in statute in the Rescue Act. And one of the criteria is to help deal with the pandemic and recovery. Another was offset lost revenue from previous years to keep the function of government going. So, and Treasury is going to issue some additional guidance. They have within 60 days upon enactment. The bill was enacted on the 11th of March, if I have my date correct. So they should have some additional resources, around 60 days after. But, it definitely seems like it could possibly, and I'm always, I hate to be so wishy-washy, because what we saw last time when they were coming out with the rules on how the CARES Act could be funded, they would come out with a rule and then come out with a rule later that would contradict the previous rule. So I would think that likely it seems like it would probably fit the criteria, and that would be up to the county to make the decision on how those resources are spent. But it seems like it could definitely be a possibility.
Thanks. And yeah, my thought of asking that question is, I think we'd do well as a county and as a coalition or task force to begin planning and really strategizing, developing some plans for how we would use investments of these federal dollars now, not wait, because I think our opportunities will be ongoing, and then we'll be ready.
The one caveat, and I'm always sensitive, and I put this out there, unlike the CARES Act, which originally had a 1-year expiration date, the Rescue Act has 4 years to spend these dollars, because it's difficult to predict. They didn't know what else people could be facing, year 2, year 3, year 4 after the pandemic. Hopefully, we'll all be in a much better spot soon. But so I think you're right to be thinking about this, but also, keep in mind these are 4-year dollars, and you guys will all decide if there's sensitivities and how those dollars get allocated on an annual basis.
Great. Thank you, Bill, for that answer, and thank you, Karen, for the question. And Karen, for what it's worth, completely agree with your sentiment on us getting ahead of that. I know we always try to be proactive and want to make sure we're using any new resources that come our way efficiently and effectively. Dr. Wilson, I see you have a question.
Yes, thanks, Member Hart. My question isn't really a grading system. It's more just to see what kind of activity you're getting in Washington from our local representatives, especially our Representative Christian Morthy, Foster, Caston. They've all expressed their interest in helping us out with this. Have they sponsored any bills, or you hear anything from their offices to help us along, because they've been very involved with the Hope Task Force over the last couple of years?
Yeah, I'd have to go back, and I didn't check to see who's on what bill and what they've sponsored this year. But historically, your delegation's been pretty good on this issue. They recognize that this is something that DuPage, faces day in and day out. So, between your senators and your members of the House, you actually have, I would say, a pretty. I would give them a more than an A, right? We've got a really good group on this issue.
Okay, thank you.
Great. Thanks, Dr. Wilson. Any other questions from any task force members or group members? If not, I do have one, but I want to give everyone else the opportunity first. Okay, seeing none. So Bill, one question I have, I know a lot of emphasis, rightly so, has been put on COVID's impacts on substance use and mental health, and that's definitely where our focus is on. But I do want us to get ahead of any potential issues outside of COVID that may be coming down the pike, and one of them is marijuana legalization or decriminalization. I know we've dealt with this in Illinois over the last couple of years, and we've heard some news come out of DC about some interest. What's the likelihood that that is addressed this year or next?
So they passed just recently the Safe Banking Act, which, the importance of that is that, if signed into law, that means that you can now bank these dollars. Previously, there's been a few state chartered banks. I've never seen a better time in Washington than today to pass some of this legislation. It's really, it's not one-sided. It is relatively bipartisan, and has always been bipartisan. But I think, is an even greater emphasis on these issues, especially with the states, the number of states that have moved forward, and I think how quickly and easily the Safe Banking Act passes just tells you what direction Washington's going. Where they're struggling a little bit and where you see some challenges on this is with what's the right limit, right? You're now starting to see what the question is, what in levels mean impaired driving, or how do you test this? And so we're almost starting to move beyond whether it's going to happen or not going to happen. It's more of a when, and it's starting to think about, okay, now with when, what are the post issues that we deal with, such as, driving, and how do we test for these in a fair, because if I'm going to get this a little bit wrong, I have a lot of doctors on the phone on this call that might criticize me, but I think if you can test, someone could smoke marijuana and can test for their system, up to like 30 days or, several days after they had it in their system. So I think that's one of the big questions that I'm hearing more and more discussed, are these sorts of issues. And then how much, on the CBD levels, like how much is the right level to put in food, and what's going to be allowable, really seems to be what a lot of folks are talking about today.
Thanks, Bill. So that's something we'll continue to keep our eye on. So I want to be respectful of time. You've been very generous with yours, Bill. Are there any questions for Bill before we move on to the next topic, which is a state focus that Dennis Brennan's going to lead us through?
Well,
okay, seeing none. Bill, thank you very much. Really appreciate you being on, and we'll continue to stay engaged with you as we hear more news coming out of Washington.
Great, and thank you. If anybody has any follow-up questions, feel free to get them, funnel the right person, and I'm happy to get you a good answer. Thank you so much.
Thanks so much for being on. Appreciate it. Okay, Dennis, why don't we go over to you? I know you are going to provide a brief status update on any state occurrences or state movement on this type of legislation. So, Dennis, feel free to proceed.
Well, thank you. There's just a few bills that may be of interest to this group, and I'll just run through a few of them quickly. And then if you have any questions, there's a House bill that's now on second reading. It takes 3 readings in each both the House and the Senate to pass. So the fact it gets to second reading usually is an indication it is proceeding. The first one is House Bill 33, which is more with insurance, but it does affect substance abuse or substance use treatment. If you no longer can an insurance company deny coverage if this passes for anybody that's been in a substance use disorder treatment recovery program. So that's one issue. There's also several bills that are out there regarding prescription drug repository. For whatever reason, this year, probably because the speaker changed, there's been a lot of bills that are mirror images that are getting out of each side. So the House will push something out and the Senate will push out the same bill. Where that goes, at some point, they've got to decide which one actually gets passed. And it used to be in prior years that the speaker would throw it into a committee or say which one was actually going to be passed. The House Bill 119 it's creating a new program called the Illinois Drug Reuse Opportunity Program Act, which allows recipients to donate drugs and people to donate it, and people to actually go to this donation group and get those drugs back. And the drugs we're talking about are prescription drugs in those cases. That's gone to third reading, so it's probably getting out of the House and going over to the Senate. There is a similar bill in the Senate It's on second reading. Same language. We assume that's going to stop at some point, but it might pass the Senate also. There is another Bill 348, which amends the Illinois Controlled Substances Act and provides that a prescriber has to offer a prescription for naloxone or similar drug. Also provides they have to provide educational information. That has been in the Rules Committee. It's not likely to get out since it's in the Rules Committee, but it's something that might come up in future sessions. House Bill 449 is called Housing as a Recovery Pilot Program. That one is going to be a pilot program. It has passed the House already. It's been sent over to the Senate. It provides an appropriation and changes the definition of serious mental illness, is meeting both the diagnostic and function criteria consistent with the definition of serious mental illness in the Illinois Department of Human Services Mental Health Community Mental Health Provider Manual. The idea is that people who are referred to the program receive rental subsidies prior to their discharge from a hospital or from a correctional facility, so they're not just back out on the street. There's also a few drug take back or disposal bills. One, House Bill 1780 is still in rules. We don't think that's getting out. But Senate Bill 590 is called the Safe Pharmaceutical Disposal Act. This one provides the county shall, it used to be may, and a municipality may authorize the use of its city hall or other facility to have a container for sharps. It used to be just pharmaceuticals. Now the county would have to have another container for sharps. Those are the bills that are really pending and moving along that you might be interested in. We've also had a discussion with Representative Deb Conroy. She is the one responsible for facilitating the $5 million for the CRC building. She's constantly checking with the governor's office, I'm told, and we are in the queue basically to get that money. The problem for any of that money is bonds have never been issued by the state, and all of that money was supposed to come forward because of bonds being issued, and it's being funded by the casinos and the marijuana money that comes in. The state is held back on issuing bonds because the credit rating is poor, so they're trying to hopefully use the federal money to build up their credit rating a little bit, so when the bonds are issued, they're not taking a big hit. But we are in line for the money. We've been told it's there. It's just we're in line with a lot of people, and we will get it eventually. She's trying to get a better idea of what timeline that would be for us. And if there's any questions, I can try to answer those.
Thank you, Dennis. Any questions for Dennis? I see Dr. Wilson has one. Dr. Wilson, please proceed.
Thank you. And thank you, Dennis, for addressing that $5 million. That money is one way that we can help keep people out of jails or out of the emergency rooms, where we can do that crisis stabilization kind of stuff, so that people would be taken to this space, and then they can make decisions for how to triage those patients appropriately. So that's great that that's moving forward. Thanks for addressing that. My question was that there's a bill to decriminalize various opioids, including fentanyl. I think it was voted on in the last couple of days. Where does that stand? And can you describe that just a little bit more for us?
Yeah, that's House Bill 3447. What it did is allowed expungement for completing certain misdemeanor diversions or certain convictions for possession of controlled substances. And it lowered, well, I guess it increased the amount that you could be holding to make it a felony. So now if you're under 3 grams, I believe, of heroin, it's not considered a felony anymore. Fentanyl, 3 grams again. Cocaine, it used to be 1, now it'll be 5. No, it will be, 1, it used to be 5. And morphine's another one. The idea, I think, is, that these people are getting treatment rather than it's more of a social justice issue, rather than being put in prison or jail. The bill has passed the House the other day, so it was delivered over to the Senate, and there are a lot of sponsors joining it. It was all, I think it was unanimously Democratic votes. I don't think there was a House Republican. In the Senate so far, that seems to be the case for sponsors, but it does seem to be something that's going forward.
Okay. Thank you. I was just curious whether it was progressing, and it is a little controversial, and but I won't add any controversy to it. I was just curious about where it stood.
Okay.
Thanks, Dr. Wilson. Any other questions? Okay, seeing none. Thank you very much, Dennis, for the very helpful update. I did notice that you mentioned some drug take-back efforts, and I do want to take this time to remind everyone that tomorrow is actually Drug Take-Back Day. So we encourage, if there's any unused prescription medications in your house, drop them off at one of the many locations throughout the county where you can drop those off and get them out of circulation. But Dennis, thank you for the state legislative update.
Thank you.
So we're going to move on to the next item on the agenda, and I'll turn it over to Dr. Wilson. I do just want to preface it by saying we've talked a couple meetings about the emphasis and renewed interest in harm reduction, which is a very broad topic. We're going to go into that in a little bit more detail, but we wanted to take this opportunity at this task force meeting to explore this issue in greater detail and depth, so that all of us as task force members are equipped to make any decisions that may be coming down the pike with regard to harm reduction. So we have a great panel discussion to go into this topic a little bit more, and it's going to be led and facilitated by my colleague, Dr. Wilson. So Dr. Wilson, I'll turn it over to you to introduce our speakers and take it from here.
Thank you, Member Hart. Great job. For those of you who are following along the agenda, you can see we have time frame, and we want to get everybody out of here we started at 9 a.m. We're going to finish at 10:30. We have set aside a half hour for this next session. Now we're starting at 10 minutes late because we moved up the state and federal legislative updates. So we're starting at 9:30-ish. We'll finish this discussion around 10 o'clock. Actually, Jim Scarpace, I'm glad that you're with us. I didn't get you in the roll call earlier. Jim is Executive Director of Gateway Foundation. And Jim, I'm happy for you to kind of lead this discussion. Let me introduce, though, Lisa Abrams, Director of Staff Training and Development with Haymarket Center, and our friend who's returned, has been a member of the Hope Task Force, but sadly leaving Edward Elmhurst recently, stepped aside from his membership, but Aaron Weiner, PhD. Dr. Weiner is a member of the Physician Speakers Bureau for the National Safety Council, the Science Advisory Board for Smart Approaches to Marijuana, and a former board member for the Society of Addiction Psychology. So one of the reasons why this discussion is so important, friends, is that we're going to be talking about HOPE funding opportunities in a few minutes. And harm reduction has been one of those touchy subjects that has applied for funding along the way, but we're hesitant to proceed with funding through the HOPE Task Force if we're not doing it right, if we're not doing it in a way that's acceptable to the community, even though it might be a positive thing for those who have substance use disorders. So this discussion is really going to be helpful for our HOPE Task Force in helping us make those kinds of decisions. Jim, would you say a couple of words? And then I believe that Lisa has a PowerPoint presentation she's going to share with us.
Sure, Dr. Wilson. Yes, thank you for, bringing this very important topic to the task force. I think that between Lisa, Aaron, and myself, as well as everyone else on the panel, there's an opportunity for discussion here to really understand better what the purpose of harm reduction is, to understand the concept, because I think when some people think of harm reduction, immediately needle exchange programs jump into the forefront of their mind, but harm reduction is so much more than that. And that's just one piece of an example of a harm reduction strategy or intervention. And so what I'm hopeful for is that we can have a better understanding of this and look at what pieces of harm reduction might the task force be a good fit to either fund or support in DuPage County. Because at the end of the day, harm reduction is about helping people get to recovery. That's really what it's about. It's about that end goal of being in recovery and being abstinent from substances, but it's a process to get there. And sometimes as treatment providers, as law enforcement officers, as business supports in the community, if we have a better understanding of this, with that being the end goal, sometimes it's easier to understand how some pieces that might normally not look like effective interventions to help people who are struggling with substance use disorder start to come to the forefront and be seen more as part of that process. So I'm hoping, I think Lisa took a lot of time to put together a PowerPoint. I think that we can use that as a kicking off point for the discussion and really start to key in on some of the components she has in the slides. So I don't know, Lisa, if you're able to share your screen or if Mila has to give you control.
I believe I can share. Can everyone see?
Yes.
Yes, it's a good start. You're going to enlarge it now for us and we'll be ready to rock and roll, I think.
Okay. Is that better?
We still see the slides on the side as well
You
as your main
change it
slide.
into presentation mode, I think.
That didn't help. How do I change it to presentation? I apologize.
You just want to go to slide. You want to click on slideshow up on top, up on the top bar. See where it says slideshow in the middle, up higher. There you go. Up. See right there. Click on that.
Right, just under the orange ribbon.
Yeah, under the orange ribbon, it says slideshow.
Oh, I'm so sorry.
And
Okay.
then from beginning.
Thank you. I'm not that tech savvy. How's that? Much better?
Yes.
I appreciate that. First, I want to say thank you for the introduction. And I'm so grateful to be here with all of you who deliver that message of hope. And I just want to honor each and every one of you for protecting and serving, the community for folks that are very sick people, not bad people trying to get better, but sick people trying to heal from their pain and trauma and all kinds of things. So thank you. It's an honor to be here with all of you and learn from all of you. So I'm just going to move through a PowerPoint relatively quickly for time's sake. I'm just going to give us like a foundation of harm reduction and, to tip off a broader discussion of that. So let me move through the slides. Okay. So some of our objectives today, what is harm reduction and where does it fit on the continuum to treatment and recovery? We'll talk about the pros and the cons of harm reduction models. And we're going to discuss harm reduction models in the Chicago metropolitan area currently. Okay, so I was an English major in my undergrad, so I love to define words and find out their origin. And so the definition of reduction is the act or fact of making a specified thing smaller or less in amount, degree, or size. And late Middle English, from Old French and Latin, comes from the word reducere, to bring back and restore. And I don't mind self-disclosing that I am in recovery myself for many years. And I can share with you that active addiction is one of the loneliest, helpless, darkest places to be, and a hopeless place, a hopeless place of mind and body. And so I love bring back and restore. That's what recovery has done for me. I had a darkened spirit and it has brightened my spirit and transformed my life. And we deliver a message of hope again in AA and NA and all the 12-step programs out there. So I'm going to cover who do we serve? People that are sick and suffering, darkened spirits, folks with significant trauma, co-occurring disorders, mental health and substance abuse, detoxing, people going through post-acute withdrawal, emotionally dysregulated people, broken, hopeless, and homeless people. I always say good person, bad disease, bad illness, and not bad people trying to get good once again, but sick people trying to get better. Folks in the criminal justice system, you know, and people are mothers and fathers and brothers and sisters and daughters and sons and cousins, you know, those are the person, you know, and I like to be very person-centered and separate the individual from the illness. So what is harm reduction? It's a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. Harm reduction incorporates a spectrum of strategies that include safer use, managed use, abstinence, meeting people whose drug use, who are using drugs, where they are at, right? We have to meet the client where they're at and addressing conditions of use along with the use itself. Because harm reduction demands that interventions and policies designed to serve people who use drugs reflect specific individual and community needs, there is really no universal definition or formula for implementing harm reduction. So here's some principles central to harm reduction practice. One, accepts for better or worse, illicit drug use is part of our world and chooses to work to minimize its harmful effects rather than simply ignore or condemn them. And I really admire your task force for everything you do because you're not condemning them. You're looking at solutions and you're not staying in the problem. So I want to thank you again for all that you do. Understands drug use as a complex, multifaceted phenomenon that encompasses a continuum of behaviors from severe use to total abstinence and acknowledges that some ways of using drugs are clearly safer than others. Number 3, establishes quality of individual and community life and well-being, not necessarily cessation of all drug use as the criteria for successful interventions and policies. So number 4, we have calls for the non-judgmental, non-coercive provision of services and resources to people who use drugs and the communities in which they live in order to assist them in reducing attendant harm. Number 5, we take a look at ensuring that people who use drugs and those with a history of drug use routinely have a real voice, you know, in the creation of programs and policies designed to serve them. And all of you have that strong voice, you know, all of us who are advocates for treatment and health, hope, and healing, we have that strong voice, and it's becoming stronger and stronger as stigma, continues to reduce. So. Number 6, affirms people who use drugs themselves as the primary agents of reducing the harms of their drug use and seeks to empower people with substance use disorder to share information and support each other in strategies which meet their actual conditions of use. A few more, recognizes that the realities of poverty and class and racism, social isolation, past trauma, sex-based discrimination, and other social inequalities affect both people's vulnerability to and capacity for effectively dealing with drug-related harm. It doesn't attempt to minimize or ignore the real and tragic harm and danger that can be associated with illicit drug use. And its focus is really on harms, and individual substance use is secondary to the potential harms that may result in that use. Some analogies. So we engage in harm reduction in our everyday lives to minimize risk, like wearing a helmet if we're riding a bike or a motorcycle, enforcing seatbelts when we're driving cars. So here's some models. Drug courts, we're all aware of that are considered diversion programs versus punitive actions. So moving from punitive to rehabilitation. Fentanyl test strips and overdose prevention. We have now emerging supervised injection sites, which I could talk about a little bit towards the end. We have Narcan, so I won't go over that. You guys all are in support of that and understand the concepts behind it. and how it works. So prescription monitoring programs are another harm reduction model. They're state-run electronic databases that collect and distribute data about the prescription and dispensation of controlled substances. And then we have decriminalization, excuse me, of illicit substances.
Hey, Lisa, would it be okay with you if we backed up one slide and maybe just spent the next 15 minutes around a discussion? Because I know we only have 15 minutes left. Is that okay?
Absolutely. Yes, absolutely.
I think I know that and I've seen the rest of your PowerPoint, and it's excellent. I know you start to go into detail about some of the harm reduction models, which is great, but I just worry that we're going to run out of time if we don't stop here. So I think this would be a good kicking off point in terms of addressing harm reduction and some of the models that maybe DuPage County would want to look at, because I think the biggest piece of this, besides trying to get people towards recovery, and Lisa did a great job outlining it, is we have to recognize that relapse is part of the recovery process. And as much as we want people to get into treatment or access services right away when they have a substance use disorder, it doesn't happen that way. And even when people do get treatment, many of them relapse along the road to recovery. And just being accepting of that and trying to determine what types of supports we can get behind to help people come forward and get help, because that's most important, not being ashamed, not being embarrassed, because reducing stigma is a harm reduction model too. Being able to help people feel okay about saying they have an issue, because they would feel okay about doing that if it was any other medical condition. And so that's a big part of this, in addition to some of these very specific intervention strategies that are tied to harm reduction model. And maybe that's where, Lisa, Aaron, you guys have some thoughts about what you've seen that's effective in terms of some of these harm reduction models, and maybe some things as a task force we may want to support.
Yeah, and I could jump in and share a couple of thoughts as well really quick, if that's all right. So everything up on the slide, I guess is a quick way to put it, it works. And we actually have very good data to support pretty much everything that's up here, in journal articles, trials that have been done across the country. And a good way to conceptualize this, and again, Lisa did a great job, and these slides are, I think you probably have access to them after the fact. I'd encourage everybody to look at the last 19 slides in the deck. They're very detailed and very good. But essentially the idea here is that, unlike with, say, like cancer, for pretty much everybody, like if you found that they had cancer, would want treatment, unless there's a really good sort of end of life reason why not to. And they would probably say, yes, let's treat that cancer and take care of it. Addiction is a disorder that has multiple different facets. There's a biological part, like cancer, but then there's also a psychological part, and there's a social part. And as a result of all of that, there's this constellation of issues that makes it so that people who are stuck in active addiction, even if it, as Lisa said, can be one of the darkest places imaginable, makes it very hard to break out of. And so all of the different options that are listed on this slide are ways to stop someone from either dying prematurely or contracting some sort of incurable disease while they're still in a state where they're not able to accept treatment, because that's part of the way addiction works. And so if you think of it almost kind of like these services not only being potentially life-saving or life buffering, but also kind of like a funnel. Like if you think about this in marketing terms, where you've got this really broad reach where you're trying to get everybody to connect with you. And that's part of where, when you think about where a lot of these harm reduction initiatives come from, they're being done by organizations like, say, the health department, that are actually trying to eventually help people get out of active addiction. And so the idea here is, if there's people who are in the throes of this disease who are not yet ready to change, if you can have them establish a relationship with you that not only buffers them from some of the most harmful elements, but means that when they are ready for change, you can swoop right in and connect them to the services they need to get better. That means that not only are you keeping them safe and alive, but you've upped the chances that they're actually going to get better when they're ready. So I think that's also a really critical way of thinking about this paradigm. Yes, even if someone never asks for that help, they will be better off because they've been exposed to these measures, like needle exchanges, like fentanyl test strips, like having naloxone on hand. But critically, they're also then able to get help much more readily when they're ready for that change. The last little wiggle I want to add in before I'll step away from the mic is I also think that we tend to focus a lot of our harm reduction efforts only on people who are towards the end stage of this disease, when they're at the point where they're overdosing, when they're at the point that they're injecting drugs, when they're at the point where they've maybe had legal consequences and end up in drug courts. And I think that there's an extreme lack of attention. And this might be a place also where DuPage can push the envelope a little bit. I know that that's what the Hope Task Force is known for, in terms of very forward-thinking ideas and principles that then can set a standard for even the rest of the country, if not the state. But really looking at secondary prevention. So secondary prevention being people who are already doing something, but not necessarily at this endpoint. So what do I mean by that? There's two main paths that people take to get to the point where they're injecting heroin. One is when they start using substances when they're younger, oftentimes either to cope with something or to fit in with a group. But they're not usually, virtually nobody starts with heroin. They're usually vaping, they're using marijuana, they're using these precursor substances essentially that prime their brain biologically to be addicted to other things, and also indoctrinate them into a culture where getting addicted to something or using addictive substances either for fun or for coping is accepted. And then that means that they're far more likely at some point to make it to this point where they would need the services listed on this slide. The other pathway is when people are prescribed opioids for either post-surgically or for some sort of injury. And then they become physically dependent on those opioids, and it starts to interact with some other things as well. But one of the hallmarks of prevention is the idea that it's much easier to stop someone from getting to the point where something has gotten terrible than to try to treat it at that point. Kind of like the reason why we promote mammograms rather than just trying to treat stage 4 metastasized breast cancer. If you're able to stop something early, it actually it could not only save lives, but actually be the better allocation of resources. So I just wanted to throw it, as we're talking about harm reduction models, everything on this slide works and is worth doing. And I think that it would be very useful also to shift our gaze a little bit earlier in the process before someone gets to the point that they need these interventions, because that's harm reduction too. Not just stopping someone from using drugs in the first place, which is what we usually think of as prevention, but thinking about harm reduction that would stop somebody from getting to the point that they might be using heroin laced with fentanyl. So, all right, that's my monologue. I'll step back.
Thank you, Aaron. And I do agree with you that I think all of these models have shown effectiveness in different platforms, across the nation. I think what we have to decide as a task force is what areas are appropriate for us to support, just based on numerous things. I mean, we all, Aaron, myself, and Lisa, are speaking as clinicians and through that lens. And that's important. But as a task force, we represent DuPage County and the governmental arms of DuPage County. And there are some things I think that we'd have to weigh pros versus cons in terms of how effective it is versus any potential liability or risk associated with it. And I think those are the things as we move forward, we'd have to decide. Example, Gateway Aurora is located in Kane County. We have Downers Grove and DuPage, but I also have Joliet and Will County. And in Will County, we are using the CARES money to do a Narcan community event where we're, handing out Narcan to the community. We're inviting people to come to be able to get that. We're using the CARES money to buy 130, 140 2-packs of Narcan and being able to give that out to the community or really, emphasize and advertise that that's going to be available, because whether you're struggling with prescription opiates or heroin, having Narcan available to you is a harm reduction component, as you see on this slide, that basically can save someone's life. And we've seen all the first responders in DuPage County talk about this over the years on the task force. I know DuPage County's done these kinds of things in the past, but that's a great example of a harm reduction model that a county organization or a governmental organization might stand behind and say, hey, this is something we can do. This is something we want to use our money for. We want to get this into people's hands. So should something occur, they're prepared to be able to reverse that opiate overdose in their homes, in their workplaces, having it available to them. Another great example, I know we talked about this in terms of the county, and this is my own platform, since Aaron talked about his being able to share his ideas, is we talked about really getting out information in order to reduce shame and embarrassment about coming forward and asking for help, and really using a campaign to reduce stigma in the county and getting information out so that people are at doctor's offices or at clinics, whether it be, the DuPage County clinics or private clinics, see, hey, treatment's available. Here's how to access treatment. It's okay to come forward. This is a disease of the brain. It can be treated. It's so funny because when I look at this as a disease of the brain, I was at my doctor's office just recently for a checkup, and my mother-in-law, coincidentally, is struggling with early stages of dementia, which is another disease of the brain, but it has a more organic component. And just like addiction, gets progressively worse, but unlike addiction, harder to recover from once you start to develop those symptoms of early stage dementia. And it was really talking about, if you're struggling with this, don't be embarrassed. Come forward. There's help. Here's a phone number. Here's who you can call. Here's how you can access services to delay or slow down this illness. To have things like that available to people in the community who are hiding their illness out of shame or fear, that's another great example of a harm reduction approach that can really help people get to services. Those are just two examples. I think that, and at least I want to give you some time to talk. I think that we just have to decide what makes sense, what's going to reach the most people and really help people get on that road to treatment and eventual recovery. Lisa, I'll turn the mic over to you.
Thank you. I'll just show a couple more slides, but I encourage everyone to read it, and I'm more than open to questions, concerns. So I did do.
Actually, really quick, it looks like Greg's raised his hand.
Oh, sorry. Okay.
The question.
Yeah, and if it's better to get through the content, I can wait. No worries. But I think this was a good time to enter some discussion. So I'll hold off and let you guys finish the content, and then maybe we go to questions from that point forward. Does that work?
Sure.
Okay.
Absolutely. I'll move quickly, 5 minutes. So needle exchange services, I think we're all aware of the background of that and the pros of that. There are pros and cons to everything. So I can just highlight a couple for needle exchange, reducing the risk of law enforcement officers becoming infected by accidental needle sticks, decreased public substance consumption, reduced costs for the healthcare system, which we're all aware of that. So feel free to read the details again. I talked about the fentanyl drug, and according to DuPage County Coroner Richard Jorgensen, there were 112 opioid deaths in 2020 in DuPage, which is a 17% increase from last year. So that's critical to recognize. I talk about test strips here. So studies by Johns Hopkins, Bloomberg School of Public Health, they showed that 70% of people who use drugs would modify their drug use behaviors if their drugs tested positive for fentanyl. And that's part of recovery, is modifying behaviors and changing perspectives. So that's important to that. And I did write some pros and cons, obviously decreased death and overdose rates. It's $1 is the cost of a testing strip. It provides real-time data about local drug supplies for public health surveillance. And the cons, could perpetuate use, as we're all aware of, or enable. And we're going to talk a little bit about how this fits into the continuum of care, where we're not continuing to enable, we're looking to support and guide and mentor folks into treatment and hopefully towards abstinence. We have our supervised drug consumption.
Lisa, I'm sorry. I'm such a strict timekeeper, and I love your presentation, as Jim had said earlier, but I think we need to spend a little time with question and answers when we've got such a powerful group as the three of you here to answer some of these questions. So I see two questions raised, including Greg and Karen. And one of the things I want to get at the end of this discussion is do we think it's okay to have needles exchange out there as one of these harm reduction models? There's some pretty strong opposition to that, despite the fact that it seems from the experts that it's okay. So Jim, you want to take over and ask? I think Greg and Karen both had their hands raised.
I'm sure. Yeah, Greg, please.
Thank you very much. And just to add on to what Dr. Wilson said too, we know that this is the first time we're discussing this topic as a task force. I know there's likely going to be questions that emanate after we get off the session today, but I think this is a great introduction and really helpful presentation. So thank you to all three of you for doing this. One question I had was, I guess I'll start by saying, one of the main missions of this task force, if not the main mission, is to save lives. That's always been what we've been focused on. That's why we invested in our CAN program. It's why we're doing drug take back. And to me, if you go back to the initial slide that listed all the harm reduction tactics, could you go back there real quick? I think it was a couple slides back.
Slide 10, I think.
Yeah. Anyway, exactly. Thank you. So drug courts, fentanyl test strips, overdose prevention. I don't want to say those are some of the lesser controversial aspects of harm reduction, but I think there would be consensus around the fact that all of those things are needed. In fact, we're using Narcan already that can be considered harm reduction, and those all directly go to helping save people's lives. But some of the criticisms I've heard of harm reduction when it relates to safe injection sites or needle exchanges is that, and I know there's data to back up the efficacy of those tactics, but the criticism is that they kind of perpetuate the ongoing use of drugs and can, perpetuate the illness. Can you guys address the data that speaks contrary to that? I know we touched on it a little bit, but it'd be really helpful to hear a little bit about how this leads someone to treatment, even though it may seem contrary to that, to the untrained eye.
Well, I could just jump in quickly and say that I'd be happy later in the day to send some of the journal articles that have studied that exact question. But you are right in saying that the data has not borne out that needle exchanges cause more people to inject drugs, just like giving out condoms on college campuses don't cause college students to have more sex. They're doing it anyway. And so it's the same general principle here. I understand that idea might seems in some ways logical, but once you get, it's kind of like I was saying earlier, once you get to this point where you are injecting drugs, the needle is simply preventing harm. It's not encouraging use. You're already pretty deep into an addiction. So I understand that there might be like a little bit of a squeamishness there, or this idea that we're directly facilitating use, but I'd be happy to share some of the research behind it that actually it just prevents harm and does not promote use.
Yeah, thanks, Aaron. That would be great. I'd love to see it. And then similarly, I don't know if there are any case studies. I'm sure we could look this up on our own, but if there's any that come to mind to the three of you of locations, counties, municipalities that have explored these options and what the results were, I think that'd be helpful for us as we wrap our heads around this issue. So thanks for your time. And I think there was another comment or question.
Yeah, just before that last question from Karen, the other thing I would say is one of the things with needle exchange programs, although there are risks associated with them, very significant risks, especially nowadays because so many people are injecting fentanyl. And, the risk of death immediately from fentanyl is very high, as we've heard Dr. Jorgensen say, and we've seen the data play out. However, with the biggest benefit of a needle exchange program, besides obviously reducing risk of HIV and other illnesses, is touch point. It's a touch point to interact with someone who you might not normally interact with or see come into a treatment center and be able to give them education and information about treatment accessibility, about reducing their fear of accessing treatment, about giving them information about what treatment really is and how it can help them so that you can get them into treatment centers. That's the biggest piece of the needle exchange program that's most effective, is it's a touch point for people that you wouldn't normally see, that wouldn't come forward.
Thank you, Jim.
Did Karen have a question too?
It was more an overarching observation, and Greg got to the essence of what I was going to ask as well. I think the reality for this HOPE task force is that in previous rounds of funding requests, we have had organizations who have requested funds for fentanyl test strips, for needle exchange, for some of these other very valuable research supported and yet still controversial kind of elements. And I think that if people have, and I don't know that we have time on the agenda to have a robust discussion amongst ourselves, but if people aren't there yet on this task force, I think it would be really helpful, and kind of to your point, Greg, what information would you need to be able to support these kind of interventions in DuPage? Or is there like nothing that would convince you of the value of these? And I think as a task force, we want to really step forward and progress in our efforts with a big tent kind of philosophy, right? We want people, maybe you're not going to be out front doing cartwheels, but at least be able to be in support of these efforts. So I think that would be very, very helpful to know. You want more information on this aspect or that aspect, or you've heard this. I'm keenly aware that with COVID-19 and the vaccination, there's social media perpetuates many myths, and we really want to make sure that we base our strategies on reliable information. So thank you.
Well said, Karen. Lisa, will you be able to provide this PowerPoint to the rest of the task force members, or have you already provided it for us? Lisa? You're muted, Lisa.
I've distributed it to Mila and Penny. If you want me to go further, I'm happy to.
It's no, that's fine. Do we have your permission to distribute it to the rest of the task force?
Absolutely.
Wonderful. It is wonderfully well done. So, and I'm sorry that I had to cut you off, but half hour goes much quicker than expected. And I just would like to hear from a few people around the room here. Anybody have any thoughts about the needle exchange program? It won't fly in my community, forget about it, or it's a great idea. Just a couple of people. Anybody want to raise their hand and say anything more?
I'll say something. My opinion is that I think we start, although we talked about some of the benefits of it, I think we need to start somewhere else and maybe look at working our way to that as a county and a task force. But I think there's some opportunities to get our feet wet with some other harm reduction strategies that could be equally effective, or could be an opportunity to connect people who we normally wouldn't reach to treatment. That's just my 2 cents.
But we have the drug course. In fact, we have a prize-winning focus court. We're doing fentanyl test strips. We're doing Narcan. The prescription monitoring program is in place. They're beginning to decriminalize. They're talking about decriminalizing illicit drugs in Springfield. So what's left but the needle exchange program? I mean, that's really, isn't that one of the biggies? Aren't we doing all the rest?
I think we're doing pieces of all the rest. I think we could do a little bit more in some other areas of those other harm reduction strategies. Again, I'm not opposed to it. I just think, as a county, it's just something we may want to look at and decide, what are the implications of doing something like this, from a county perspective. That's all.
Brad Gerke, do you want to say anything about this?
Yeah, thank you, Dr. Wilson. I'm a very strong believer in harm reduction when it comes to Narcan, when it comes to fentanyl test strips, when it comes to advocacy, trying to break the stigma, getting out there in the public, drawing them in to get education, awareness, and resources. I would say my opinion, and I believe I need to speak my truth, is when it comes to the actual needle exchange programs, those make me nervous as somebody in recovery. I've kind of took it upon myself to ask some people that are in recovery and their opinions as well. And they kind of had the same perspective of, having a place to go. And these things were out there when I was out there getting high too. And one, we never really went to them. But even before that, right, like when I started using heroin, I was sniffing it. I still had majority of my friends alive at that time. When we graduated to using the needle, that's when I started seeing people pass away and overdose from this disease. Now, as Aaron pointed out, yes, it's true. If you're already using a needle, you're going to find one way or another to use it. And if there is a needle exchange, yes, it'll be a clean needle. My concern with that is, and to admit, when I was out there getting high, same with all my other friends, if you have a dirty needle on you, you're afraid of getting caught with it. Therefore, a charge of a paraphernalia charge. So will it be helping out somebody in recovery of not catching hepatitis C, not catching HIV? Yes. But what are they doing with those needles if they have those diseases? I know for myself, when I was homeless, I didn't have places to put things. So are there going to be needles laying around? Honestly, my concern with DuPage County, I believe we have started breaking the stigma and introducing harm reduction. Narcan has been very receptive. If anything came of a needle exchange program, I believe it would have to be introduced in the right way to not create more of a stigma, more of a pushback, more of a concern for the general public. What we don't want to do is create more of a cloud over addiction with doing this. So I'm interested to see what the statistics are, what the facts are with these programs, and who put together the data, where it's coming from, if it's coming from one side or another, if it's neutral. But for myself, I do get concerned with supplying ultimately the weapon that could kill. If you don't have a needle and you have a bag of dope, you're still going to use that dope. If that dope has fentanyl and you sniff it, you're much more less likely to overdose from it than if you're shooting.
Thank you, Brad. I know that we're running short on time, but is there anyone else who wants to say something about this issue right now? You can see that this is an important issue that we're going to be revisiting again, of course.
Dr. Wilson, I think Mila and Jeff York have a comment. I see in the chat.
Just a quick comment to ask Jim and Lisa and Aaron, do you have any, look at those fentanyl test strips and think it's an opportunity that we may have to pair that with our Narcan program. And I just want to get a sense from you on education that might need to go with that or how to make that successful.
Are you asking, should we pair the fentanyl test strips with the Narcan program?
Just some examples of if you've seen opportunities to share those test strips and get them out there. And that's one way that I'm thinking about it, but open to other suggestions too.
I think that getting fentanyl test strips out there as much as possible with Narcan is important. Both of those things can save someone's life.
Mm-hmm. And I'll jump in really quickly because I actually need to go in just a second. But I really appreciate the opportunity to contribute today. So really the aspect of fentanyl test strips is very similar to naloxone in that you somehow need to get them to the people who will use them. And so this issue of a touch point and creating opportunities for people either to come in and interact with you, or I know Mila mentioned that you're now doing delivery of naloxone, which I think is fantastic. So maybe if someone would be hesitant to come out publicly, even to a public building, that you'd get that to them. I guess the last thing that I'd say, and I will send, I'll send in quite a few research articles later in the day about this, is that I completely appreciate all the different approaches to this. I know that I feel very strongly that we have to be guided by data at the end of the day. And that doesn't necessarily mean that we should do a needle exchange. I think that there are a lot of considerations to it. But I think what you'll find when you look at the data behind it is that people who do actually engage with these programs are far more likely to eventually attend treatment and recover than those who do not, because of that touch point, because they've built trust with an organization, because you're there ready to help. And so there's a lot of ways to do that, right? The critical element there is not the needle. The critical element there is the connection and finding these people. And particularly in a county like DuPage, where we don't have hotspots. I was talking to Mila about this as well. It's not like we can do a safe injection facility and put it down in a hot zone and supervise people and reduce death that way. People are spread out all over the county. They're overdosing in lots of different environments. And it's much harder to reach them in that way. So if you were actually able to put down something that attracted people to you, either virtually or in person, so that you could connect with them, you could get their email, you could get their phone number, you could get their consent to contact and build that relationship. However we choose to do that, that would be a really powerful thing, needles or otherwise. So I just want to end with that. And thank you again, folks, for giving me the opportunity to contribute today.
Thank you, Dr. Weiner. We look forward to being in touch for sure. And Jeff York had a question.
Not really a question. I just think an opportunity potentially for this task force is to look at deflection, really from getting into the criminal justice system. So before you get to focus, before you get to drug court, I mean, those are kind of two extremes, but the new safety legislation expands Illinois' opportunities to both use police officers and fire and EMS. I think there's money through the Illinois Criminal Justice Authority for deflection programs so that people who interact with someone who's using has the opportunity to engage them in treatment. And so that's going to take money and resources, but a lot of the people that would need to do that are here, treatment providers, fire, EMS, and that kind of thing. So I would like to see us maybe at least look at programs to expand the small deflection programs that have been done in very silo type ways more broadly.
Thank you, Jeff. Seeing no other hands raised, I think it's time to move on. But boy, this is such an important subject. We've scratched the surface of this, and we need to continue having these conversations. Greg, may I turn it over to you now for the next part of the meeting?
Yes, that's if I could get my mute button fixed. Anyway, thank you, Dr. Wilson. I just want to go what you said. In many cases, this is the first time we're talking about it collectively as a group. There's a lot of information to wrap our head around, a lot of thoughts. So I do encourage everyone to review the content that's going to be coming to us via email. I do also want to make a point, every type of tactic that we've dealt with to date on this task force at one point in time, whether it was Narcan or drug court or, treatment, I mean, it has been controversial at one point in time, right? And the way we progress as a county, as healthcare providers, is by following the data. So I do want to echo a little bit of what Dr. Warner said, Aaron Weiner said, and yes, it is my own personal opinion, but that's kind of where I hope we go as a task force in terms of the openness and open-mindedness that we view this issue. So first conversation we're having, we'll definitely have more, and we look forward to getting more thoughts from this group as we proceed. So moving on to the next item on the agenda. As everyone knows, one of the key ways we engage with the community and one of the key outputs we have as a task force is through our funding rounds, where we invest in different programs in the community that we think can have an impact at addressing the opioid and substance use epidemic. And we do have an additional funding round coming up shortly. And I wanted to turn it over to Mila just to talk through the specifics on that so that everyone's aware and that anyone who's watching from home has an awareness about this opportunity for different programs. So Mila, please take it from here.
Thank you, Greg. So we are very excited to once again announce a funding opportunity through the HOPE Task Force, and we will be providing a press release with details on Monday with information to be found on the hope2page.org website. The funding opportunity allows for a total of $125,000 of funds to be allocated, with projects that would range between $25,000 and $50,000 apiece. We have a timeline identified in some project guidelines that will be in the information, but we are once again focusing on treatment and recovery as an area of focus within our framework. And this round, we have added overdose response and prevention, which would include harm reduction programs, which is part of the reason why we had our discussion this morning to learn a little bit more about what some of those models might look like. The proposed project will be serving primarily DuPage County residents, and treatment and recovery services must accept Medicaid or individuals that are uninsured to be considered. The applications, we're hoping for some new projects and innovative applications to bring new services to DuPage County residents, and the project period will be a duration of 12 months. So I wanted to run through the timeline a little bit so you can kind of get a sense of where we're at, because we will be once again asking for your help to review the applications. And the Hope Task Force members that have reviewed applications in the past have been really great to help us find the applications that are going to be of most benefit to the county. The timeline will be the press release on Monday with a new opportunity. We are going to host a general grant writing webinar on May 3rd. We are lucky to have Sarah Troll as a somewhat of our local grant expert. She has been highly involved in putting the structure together, and we will be hosting a webinar virtually May 3rd to answer questions about the application and to walk through some general grant writing discussion that applicants may have. Sarah has also offered to review questions up and until May 18th so that we all can provide the best information to all the potential grantees. And then the application itself will be due by noon on May 21st. So that is the timeline for the application process. We're excited to make the announcement and have the support of both the Hope Task Force and the County Board. Greg, I can turn it back over to you or take any questions.
Yeah, and if I could just jump in, this is thanks to the amazing and ongoing support from the County Board for allocating these dollars through the, I think it's Judicial and Public Safety budget. So really demonstrating putting their money where their mouths are. So we very much appreciate that. And thanks so much, Mila. The structure and including some of these assists ahead of the actual grant application is really from both observation as well as really wanting to support organizations and groups within our community who may not be well versed in writing grants and in complying with the whole grant process. So we want to, our goal is not to not fund programs. Our goal is to fund programs that provide effective outcomes. And it really thanks to Mila's group for putting that together.
Thank you, Karen. Thank you, Mila. And one thing that we'll be looking to all the task force members to assist with is once this is formally announced and the release goes out, we'd love your participation and help in promoting this funding opportunity. As Mila mentioned, it's open to a number of different groups, 501c3s, government entities, and we're only as good as the applications we get. So we really want to make sure that we're casting a wide net, getting as many qualified groups to apply as we can. So we'd love your help in promoting this opportunity. And as you all know, the programs that we've invested in to date have been fantastic. I think have yielded great benefits and have been very innovative. And that's obviously the lens that we're looking at when we select future projects. So more to come on that. And with that, I think we are done with the formal agenda items, Dr. Wilson. So if we wanted to, in the last 7 minutes, go to roundtable, I'll turn it over to you to manage that one. And I do see Member Schwarzy has a comment. So maybe we go to him first.
Perfecto. Looking forward to that. You were very efficient, Mr. Hart. So thank you so much. We've got a few minutes for roundtable. One of my favorite parts of the whole time we spent together. So first to Greg Schwartzy. Did I do that right this time?
Yeah, very, very good. Thank you very much. Thank you. And so this is the roundtable portion, and that's why I raised my hand. And I know we only have a few minutes, but something that at least I'd like to throw out and maybe may have the opportunity for more discussion at our next meeting is I've been a big proponent of education. I mean, unfortunately, this is a disease that requires us to be reactive. But there's obviously also a proactive element to this, and that's like Dr. Weiner mentioned earlier. It's easier to stop this occurring than to have to try to work at fixing it. So my obviously goal, and I'm new to this board, and you guys may have had this discussion 6 months ago, who knows, but being that I'm new, I'm going to bring it up. But my long-term goal would to have sort of a state mandated opioid prevention program for middle school. I know that many school districts work in the 5th grade level with their DARE programs, assuming they even have a DARE program. What are our options, at least in DuPage County, for getting education, at a minimum, out there a little bit better than it already is? I know some school districts are great about it, others aren't. Is this something, and maybe our regional superintendent, Ms. Rositi, can answer this, but to me, this is near and dear as far as trying to get the education aspect of this out there to a greater extent.
Great comments, Greg. So happy to have you aboard. And aren't we fortunate to have Superintendent Rositi here to help answer that question?
Hi, good morning. You're right, Greg. It's done differently and it's done better in some areas than in other areas. And certainly middle school is an area of concern because we know what the research says. We really do have to start there. It starts there. I will say that one of the biggest areas, and this has been happening, not just during COVID, but even previously, is really focusing on social and emotional skills of our students. So, like teaching them about good decision-making, good problem solving, practicing mindfulness, things like that, So there's a lot of concentration in that particular arena. We also have, and I should back up and just say, I'm not opposed to legislation. The problem will be, we already have something, and Lord knows with this new round of legislation coming out, how many more unfunded mandates, that there will be. So that's going to be part of the problem. But I do know that this next year, we will continue to focus really strongly on mental health, really strongly. When the school districts, the dollars that they have, like right now, as we're having discussions about this, it's somewhat not restricted, but a certain percentage has to go to learning loss, so percentage of those dollars that our districts are getting. But the other thing is that we're really focusing on those dollars with behavior interventionists, working again with the social emotional learning, having more social workers. So it really is an opportunity to really kind of intertwine. I think the biggest thing that we have in our education system is that, okay, we have to teach sex ed and sexual harassment and drug prevention. It's like, so if we can do a better job, and we do work on this in trying to connect the dots, how do these things interface with each other? So we're not doing everything's in a separate silo, but kind of bringing it, together. There is a lot happening. And I have said this before, we are so open. I have a nurses network. I have a social worker network. I have a high school social worker network. I have a counselor network. I have a dean network. All of these networks, I would welcome the opportunity to have folks from this task force come and talk to these networks. So there's a representative from all 42 school districts, that attend these opportunities. We try to have it on our agenda, to have a discussion about it. But obviously other things sometimes take precedence given what's going on. But there are opportunities, and I will tell you, I'd be happy to work with you, Greg, and anyone else who wants to continue this conversation.
That is a wonderful answer. Thank you so much. And I think substance use disorders are a subset of that behavioral health conversation that you'll be having. So thank you so much. Before we leave today, and we've only got a couple more minutes, I want to hear from Kenneth Popejoy. If Judge Popejoy, welcome aboard. How was your time with us today? What do you think?
Well, it's fascinating. There's a lot to take in, that's for sure. I read the previous meeting's minutes and was excited to get in here and meet with all of you. I've had some interaction with the health department. I've had a lot of interaction over the years with Dr. Jorgensen. And I'm just starting to get some interaction with the county board and our state's attorney and public defender in the role as chief judge. I find this job is a giant game of whack-a-mole. You never know what's coming up where, when, or how, but this has been very insightful today. I want to be involved in it 100%, supported 100%. As you've said, we've had drug-winning reactions to our drug court and focus court that we have here. We created a specialty court division just to deal with some of these issues specifically, with Ann Celine, O'Halloran Walsh presiding over that. And we're anxious to continue to fill any need that is needed in regard to this committee and this group and this task force and what the members need. So I'm open to every constructive comment and criticism there is, and every help that you can give me in learning this process. And I'm in the job for 3 years, and I'm anxious to be an active part of it for my entire time here. Thank you very much.
Welcome aboard.
Thank you.
And we have 1 minute. Is there anyone that has a burning issue that must be said before we leave today? I have one thought. Would anybody have a problem if we made this a 2-hour meeting rather than a 1.5-hour meeting? It seems like we have to kind of rush. I was so embarrassed to have to stop Lisa in the middle of your beautiful presentation, so my apologies for that. But this discussion, these roundtable discussion at the end where we pull all this together is so important, and we've had to cut that short. So I'm going to propose, now we can't vote on it, but unless there's strong objection, I'll talk to our executive group, including Mr. Hart. I don't know whether you call him Mr. Hart or Member Hart, but Greg, I think that a 2-hour meeting might be worthwhile.
Yeah, and Greg's just fine, Lana. You can go with that.
Thanks.
I would agree, effective at the next meeting, of course. But if anyone has any concerns, and we know 2 hours is a lot of time to block out of your day, which is why we totally understand any scheduling conflicts that may arise. But I think it would be effective to, for those that can stand the line at the next meeting, to move it to 2 hours. That way we're not rushing through content, especially as we're dealing with issues like harm reduction, like treatment that really require some meaty conversations. I think it'd be better not to be rushed. So it's good with me, but if anyone has any concerns, just email Lanny or myself.
Good. And you can close us out, partner.
Great. Well, first and foremost, thank you so much for everyone's participation. We do want to welcome our new members once again and their contributions. Member Schwarzy, I really appreciate your comments as well, so thank you for raising them. I do want to make note that Mila just sent something in the chat that the prevention leadership team is hosting a Teens Talk mental health conversation. The info and logistics around that will be shared via email, so look out for that. Again, we talked about drug take back day tomorrow, so please recognize that in your own right. And most importantly, please do go through the harm reduction statistics data that we're going to be receiving via email. And we appreciate everyone's engagement. Thank you so much for your time today. And with that, we'll adjourn.
Deal.
Thank you.
Thank you. Good day, everybody.
Take
Great
care.
discussion. Really appreciate everybody being here.
Thank you. Take care.
Thank you, everyone.